Good morning, good afternoon, folks. We are just waiting for our first presenter to get on the line. We're having some connectivity issues, so some things don't change in a global pandemic.
I'm on.
Oh, Sinead, hi, welcome. Okay, great. Melissa, I'll take it over to you.
Hi everyone, once again, welcome to our webinar. We are so excited to have you join us today. My name is Melissa Magongo, as Jessica has introduced me. I'm a project manager at Vetarish I. Today in South Africa, it's 14th day of the national 21-day lockdown. We don't know yet if it will be extended or not, but it's just worth mentioning because today we'll be talking about the impact of COVID-19 in clinical trials and whether the lockdown is extended or not also has a bearing on the work that we do. So rules of engagement, you are all in muted mode, just so we can make sure that our line is clean since we are recording it. But if you have a question, feel free to use our chat feature, type your question there. But at some point, we will also open up the lines for people to just really speak and ask questions. So you'll be given that opportunity. In our conversation today, we will have Sinead lead the discussion on how from a PI perspective, on how the pandemic is affecting clinical trials in Sub Saharan Africa. She will speak to us about the impact that this has on data. And she will also present to us an overview of some of the emerging COVID-19 related trials and their significance. Also on the line, I'm happy to say that we have community engagement experts from, oh, somebody just sent a message that they can't hear me. Can you hear me now?
I can hear you, Melissa.
Oh, thanks, Sinead. So on the line, we also have a lot of community engagement practitioners from different countries, such as South Africa, Zambia, Zimbabwe, Kenya, Uganda, who will also be sharing with us what the implications of the pandemic have been for their work. How are they able to engage with the communities under the circumstances? So to introduce Sinead, who most of you on the line already know and have worked with. She is the director at Vetarish I and based in Joburg, South Africa. Her research has focused on the intersections between sexual and reproductive health and HIV, especially in adolescents. She has worked on several phase 3 trials of new HIV prevention technologies, including PrEP, and she's the current protocol chair of a phase 3 HPTN-084 trial. She also serves on several advisory committees, including the WHO. So, Prof Sinead, I'll hand it over to you to start this conversation from a PI perspective, to just tell us what the pandemic's impact has been on the work that we do.
Thanks very much, Melissa, for the introduction, and good afternoon to all of you. And thanks very much to the CASPER team for inviting me to speak. I'm not sure how much time I have, but I am going to try to address the 3 questions that Melissa posed. So how has COVID-19 impacted existing, and I would say HIV prevention trials in our region? What does this mean in terms of the data and the analysis and our ability to answer some of these important questions? And what can I perhaps tell you about emerging trials or trials that have been developed in response to COVID-19 in the region? So in terms of how it's impacted trials, I think we've seen one of two responses, and probably those responses were really divided into sort of some, I think, initial awareness that this may be an issue for the African region, but no, kind of no imminent threat. To then, over a very rapid period, I think a recognition as the cases particularly started to emerge in South Africa and then kind of in other countries in the region, that this was indeed going to be a problem for us in Sub-Saharan Africa. And what you saw is that countries very rapidly locked down for variable periods of time, ranging sort of from 14 to 28 days. And I think, as Melissa said, we're in day 14 of a lockdown in South Africa, but many people believe that, kind of these lockdowns may go on for longer periods. And within that, I think project teams have sort of had to be responsive, and so started with all the infection control measures that were recommended by WHO. And some of the things that we've seen are things like increasing the availability of PPE, starting to message to participants about COVID-19, screening participants as they come into clinics. And then I think as these lockdowns took place, we started to really have to adapt our trials. And in some instances, sites have closed completely. And that kind of creates a set of challenges. But in many instances, teams have been able to soldier on, in part because in many countries in our region, healthcare workers are granted exemption status and are seen as essential services. And I think in places like South Africa, it was very helpful, in fact, when the South African government made it very clear that PrEP was considered an essential service and that PrEP should continue. So this idea that HIV prevention as well as treatment services are incredibly important. And what we've really seen is teams be very creative and think about how to basically practice social distancing by reducing the number of participants in the clinic at any point in time, and also the number of staff at any point in time, and also shielding staff that may have underlying comorbidities that might put them at increased risk. And we've all learned, I think, how to use Zoom or other remote applications to basically continue work. Some of the other innovations have, or one of, I think, the key things that helped were for a lot of ethics committees to provide guidance, which then sort of was enabling. Most trials, I think, have stopped, if they're not COVID related, have actually stopped enrolling. And that was sort of one of the biggest interventions across many sites, was to pause all enrollment. I think the second thing has been the opportunity to do visit procedures remotely. So to either do them by telephone and to try to think about what needs to be done in clinic versus what can be done remotely, and what sort of needs to be done to secure that. And so I think it's interesting how, kind of many of our trials have really adapted to the new normal after kind of some additional working through. There's also in some trials the potential to deliver products remotely. And so that is sort of also an innovation. And then we've also heard of trial staff or participants who do need to come on to clinic, instead of asking them to travel by public transport, to assist them by kind of collecting them and doing that in a safer way as possible, and ensuring that, for example, drivers are supported by having all the necessary exemption certificates. So the other places where we've seen the kind of restrictions around COVID-19 impact trials is in PPE, personal protective equipment, getting in to countries. It's also being prioritized for frontline workers, but making sure that staff have the personal protective equipment. I think there's also been a lot of variation in the guidance that countries are giving around what constitutes PPE. And I think institutions like WHO have provided guidance, which is strongly based on evidence, but we're also seeing transitions like recommendations now coming out in South Africa about, kind of the potential to use non-medical masks, for example. And those are really, kind of additional measures that are aimed at kind of enhancing cough etiquette or reducing droplet spread. So there's no evidence for people that it would protect against acquisition of infection, but it really sort of it hopefully reduces then the demand for medical equipment, which really will need to be used in sort of amongst frontline healthcare workers. We've also seen that the impacts on travel mean that transport of, for example, study products, drug or laboratory reagents has also been impacted. And if those go on for prolonged periods of time, it may be much harder to do some of the things that we're doing now in the way of sort of remote product delivery or continuing to do testing. But even then, what we see is enormous creativity and innovation and sort of a huge commitment to trying to keep things going, which is all very, very heartening. And so there are lots of examples of I think, real creativity in the face of this crisis, and, kind of a lot of commitment to continuing to communicate despite kind of the restrictions we're all facing. So then maybe just jumping to sort of the second question of how is this impacting on our data? And I think that that's really where, for many of us, we have to think about how long is this going to go on for? And, what does this mean for our trials and the integrity of our trials? There is a belief that these trials remain incredibly important, and that when COVID-19 eventually goes away, we will still have the challenges around HIV, TB, and other similar issues, and it will be incredibly important that the trials are preserved to some extent and we are able to use the data. So at a very practical level, at a site level, that's why as much as possible we're trying to fill in the missing information by keeping engaged with participants, keeping track of where they are regularly, and trying to conduct visits remotely, even if that information is kind of incomplete. And in some of at least one trial I've been involved in, some of the discussion is, can we come up with a metric of disruption, which is about, maybe a combination of what proportion of sites in a trial were closed, how many participants are lost to follow up, what proportions of visits with sort of either intervention or, kind of outcomes like HIV testing were missed. And can we perhaps think about ways to handle that data in such a way that it doesn't impact on the trial? So can we perhaps think about censoring or kind of identifying where the disruption began, identifying where it ends, and perhaps not including the relevant data from the period of disruption, but being able to pick up where we left off. And the most important thing about being able to pick up where we left off is having a good sense that there will be participants who will still be engaged and that they will come back. And this is where it's incredibly important that teams are continuing to communicate and engage and keep track of participants so that they are able to return to their studies. I think there are some unknowns. For example, kind of will this be so disruptive that people decide not to come back to our studies, that they, kind of perhaps lose faith in health systems? And those are things, again, I think we can mitigate against by providing good, clear, reliable information during a period of crisis so that we retain people's trust and so that they continue to kind of return to us. With the hope that, kind of we can then continue our trials and kind of get the answers that we need despite this disruption. So then shifting a little bit to the emerging trials, there is a lot of interest. So first of all, there was a lot of interest in treatment trials, and that's completely appropriate. What can we do to kind of reduce the mortality rate associated with this disease? And the WHO has launched an initiative aimed at evaluating a number of drugs in countries around the world. South Africa is one of those countries. And that's looking really at treatments that either have in vitro activity or some early activity against SARS-CoV-2. And one of the important things is that we've learned a lot from the SARS epidemic and the MERS epidemic. And so we have a little bit of knowledge about how some of these drugs worked under those conditions. And people are then considering how to address those questions. I'm sure that all of you, if you've been paying attention to the media, will have heard a lot of the statements being made by, including the US president, about how some drugs like hydroxychloroquine or azithromycin could be used to treat COVID-19. And I think that sort of the response from the scientific community is that, we really do need well-designed trials that are well conducted according to ethical standards so that we can get proper answers to these questions. What we don't want to do is use drugs that could potentially have consequences for people where there's more risk than benefit. And so, well-designed placebo-controlled trials in a crisis are incredibly important. Otherwise, we're using drugs on people where we don't even know if there's a benefit. There may be a harm because of side effects. But also, we may be taking certain drugs away from people for proven indications and giving them to people where we've got no proof that, in fact, there's going to be benefit. And perhaps if people are misusing these drugs, they may also not take adequate other precautions to protect themselves. So those are the trials that are focused on treatment, and there are a number of them. There is also a lot of interest in the potential to do pre-exposure prophylaxis, and healthcare workers are one particular group that are going to be exposed to people with COVID-19, particularly in our region, and they may be at higher risk because they're seeing many people, and they may also be exposed to people who have a lot of viral shedding and therefore may be more likely to be infected. Now, we know that many people who get infected may have asymptomatic infection, but what we don't want is a lot of healthcare workers to be sick and some to get severely ill, because we really need them to be able to sustain our response to COVID-19. So there are 2 trials at least that are going to be launched, one in the African region, possibly a second, that are looking at using chloroquine to see whether that can be used as pre-exposure prophylaxis. This would be a placebo-controlled trial. It's based on the idea that there is some in vitro activity that's been observed by chloroquine against SARS-CoV-2. And even if it's not able to prevent infection, what it may do is reduce the severity of infection. And for us, having a healthcare worker out of the clinic or hospital for 5 days is better than having them in ICU for a couple of weeks. So those trials hopefully will start in the next couple of weeks and will give us answers about whether chloroquine is an effective prophylaxis. It's important to note that these are placebo-controlled trials because we don't know whether that's true. And what we know is that there may be other drugs and or monoclonal antibodies, which could also be used to protect groups like healthcare workers. So there probably will be other trials that get launched. And then the last group of trials, which I think have generated a lot of interest and a lot of discussion, and I'll be very curious to hear your comments on this, is really the vaccine trials. And what we have heard really is, kind of how rapidly the first vaccine trial went from vaccine design through to actually be a GMP manufactured vaccine that could be tested as a first in humans phase 1 study. And that timeline was shortened to 65 days. And those trials are ongoing. And in fact, vaccine trial participants are almost due to receive their second injection. So ultimately, for infectious diseases like COVID-19, we will need vaccines. We know this about that the best way to control an infectious disease is to prevent it through vaccines. And though these trials are going to be incredibly important to do, there are a number of candidates that are there are 3 candidates that are in phase 1 trials, and several more candidates that are being developed. And at some point, we will move from the safety and immunogenicity studies into the phase 3 trials, and it will be very important that we're able to see whether these vaccines work, because we think, given our experience with SARS and MERS and now COVID-19, that these coronaviruses will come back, and that they may become seasonal, and it will be important to have preventive measures in the same way we do for other infectious diseases, so that we can avoid situations like this worldwide pandemic. So those, I think, are some of the interesting initiatives. I haven't given a lot of detail, and I apologize, I haven't put this all onto slides, but it's felt a little bit like, kind of every day is something different. So I hope this gives you a useful flavor, and I'm happy to be part of the discussion and to hear other people's thoughts and comments.
Sinead, that was wonderful. That really provides a great framework. And I know we have a few actual stakeholder engagement practitioners coming up from various countries. But I did just want to ask a few questions that have come in and some comments. One question that I personally had was, you discussed all the preparations for the site, which is extensive, I know, and hard to manage, but I'm wondering about the preparations for things that the site can't control, like supply chains and potential slowdowns of study visits that may not be able to predict, and how you might be preparing participants for that. I guess the first question is, are you concerned at all about any supply chain issues and whether or not study product may actually get there?
Yeah, I think this is a concern, and we monitor it. And what we've seen in the region so far is that cargo is able to move, just not lots of people on planes. But sometimes if airports are closed down, we're having to rely on road routes. And so things are going to take longer. So I think the great thing is that there's a lot of creativity to try to figure out how to get things into places. And as long as there's not a complete shutdown. And I think the important thing for the region is that the region does also need to, in some ways, kind of maintain or continuity or business continuity. So, there have, from an economic perspective, there have been enormous commitments to try to practice all the infection prevention measures while still ensuring that to some extent the economy rumbles on. And for that reason, I do think there will still be movement, but it's often very slow. And so what that means is site teams being able to forecast and not to kind of leave things down to a margin, but really to try and get supply in sufficient quantity. But there have been also concerns about, just that products aren't being manufactured. And I think that that's where it's also sort of been challenging, where whole factories closed down just because, kind of that town closed down. So being able to kind of source from different places has also become sort of another creative approach to kind of solving this problem. So I hope that it's not insurmountable, but it certainly is challenging.
No, great. That's really helpful. And I think that leads into another question. If you could just discuss what responses people are having to potential trial pauses, closures, and the use of telemedicine in the past 2 weeks in South Africa, and from the region in general.
Mm-hmm. Yeah, no, I've been lucky to work on one of the trials that I do. So I've had lots of calls with lots of people in many of the countries in the region. And I've just been incredibly impressed at sort of the commitment and resilience of all the trial staff, but also the participants to kind of keep on going. I think what we're hearing is that participants recognize that trial sites are often sources of quality care and trusted information, and that participants are coming in for visits, but also have been hugely appreciative of the adaptations that have been made, like bringing them in safely or trying to do phone calls. And we haven't heard much negative feedback. I think we have to be very careful to make sure that we're able to preserve things like confidentiality if we do remote calls, and we have put a lot of mechanism, at least in the trials that I'm involved, I hear of a lot of attempts to kind of make sure that the person you're speaking to is the person who's on the trial. There's a lot of sort of work around trying to collect as good information as possible, sharing photos, that kind of thing. But generally it's been well received, I would say. And I think has taught us a lot of things we didn't think were possible, but are kind of in times of crisis.
Yeah, and I think that really, the idea of just sort of screening who is on the call really, and privacy issues really brings up sort of the point of the call for ethical research in this time. And Mitchell Warren, the director of AVAC, posted a link to a sign-on letter for a call that several people on the call have already signed on, just calling for ethical research in this time, and not just the research, but also actual product rollout as well. So we encourage folks to look at that sign-on letter and considering adding your names. But I do want to continue this conversation, and I also think this idea of how participants might be handling telemedicine is also something that some of our community engagement experts in the real world can answer this as well. So I want to turn it over to Meliswa to pose some questions to these individuals as well. And again, we really encourage everyone to continue asking their questions in the chat function, or again, raising your hand if you'd like to ask it verbally to one of the panelists today. So Meliswa?
Thank you so much, Jess. I just want to ask Sinead as well, before we turn it over to our community engagement as experts. I just want to find out, what are some of the measures that are being taken to ensure that we continue with our HIV response work, the HIV testing, etc., and other sexual reproductive health activities?
Yeah, that's a good question, Meliswa. And I noticed that there was I wasn't able to join, but WHO, for example, had a webinar on sort of how COVID-19 is impacting on family planning services. And I know, kind of our government in South Africa and our PEPFAR program has recognized that one of the potentially one of the most important COVID-19 responses is to make sure that people living with HIV do know their status and are on medication and well controlled, because that may minimize the severity of COVID-19 if they do get it. So I would say that in most countries, also as signified by the fact that healthcare workers have exemptions to work, that there is a recognition of the need to provide essential services. And I think that perhaps unlike other regions, we have had the Ebola experience in West Africa, where what we saw is that we had enormous loss of life amongst healthcare workers in the early phase, and how that really devastated the health system in several countries in West Africa, and led subsequently to outbreaks of infectious diseases because of failures of the immunization program. Or inability, higher maternal mortality because of breakdowns in the health system. So that is, I think, informing a lot of the responses of governments in the region, is really to try to be as aggressive as possible in, as they say, flattening the curve, reducing the potential impact on our health services, and making sure that we preserve the health workforce by ensuring that we buy ourselves enough time to get PPE into the country. I can maybe respond to sort of one of the other chat questions is, are our governments doing enough in terms of testing? And some of you may know that at least this weekend in South Africa, they launched a big community testing program, which is really trying to, as we've seen in other countries, scale up testing so that we know where the epidemic is, so that we can begin the containment efforts to try and interrupt transmission. So there are a number of community outreach workers that have previously worked on HIV testing programs who are now being repurposed to do contact tracing, to do screening and linkage to testing in order to really help us understand where infection is and how we can perhaps respond. But at the same time, what's been very interesting as a kind of model of integration is to say, well, if you're going to all these houses, is there some way that you can take medications to people instead of expecting them to come to clinics? So there is a lot of thinking. I think that, it's not perfect. Many of these ideas are being put into practice kind of literally sort of overnight, but it's been really incredible to see the mobilization around this issue and the real sort of desire, I think, to make sure that we come out the other end of this epidemic.
Thank you so much, Sinead. You spoke a lot about how it's important for us to continue maintaining contact with our participants throughout the lockdown. And I know that all sides are doing considerable work in trying to reach to participants. But I just want to turn it now to the community engagement experts that are in the webinar. And find out from them what challenges have they had in trying to reach participants and trying to maintain contact. Because I know that we have some colleagues on the line from Uganda, for instance, that work with fishing communities who have challenges in accessing maybe the internet, etc. So how have they been engaging with participants? And I'd like to ask that they must feel free to just jump into the conversation, because the challenge, our little challenge, is that our limit is 100 participants. So some of our main speakers haven't been able to join. So any of our community engagement experts, please feel free to just jump in and share.
Hello? Hello? Hello?
Hi, Vincent. Go ahead. We can hear you.
Okay, this is Vincent from Uganda. Yeah, it's right that we are really facing lots of challenges accessing and passing on information to some of our study participants who come from hard to reach communities like fishing communities. But what we did was we tried as much as possible to use phone contacts. And we are also trying to use our peer leaders network to make sure that we can get this information to the participants. Basically, for the rural setting in Uganda, the use of the internet, but we also have a few participants who are on WhatsApp and other social media platforms. But basically, it's a big challenge, especially now that we are under this lockdown.
So Vincent, has your group been able, so number one, can you tell the audience today just where in Uganda you're working, what group you're working for, so we have a little bit of a background?
Okay, sorry, I'm sorry, I didn't give that. I thought we are in the usual teleconferences. I work with the Medical Research Council, Uganda Virus Research Institute, and London School of Hygiene and Tropical Medicine. I'm based at the Masaka field station. So we are basically working on HIV prevention research and also conducting clinical trials on HIV vaccines and other diseases like malaria, Ebola, etc.
Great. So I think that answers a great background question. But how is Uganda and your participants dealing with the new sort of telemedicine and virtual engagement in the time of COVID?
That's what I said. It's really hard because we are trying our best to make sure. That's why I'm in office now. We are trying our best to make sure that we reach out to people, sort of answer their fears about the COVID-19, and also tell them and keep them informed as to when we get any new information. But this is quite challenging, I must admit.
So what sort of engagement methods beyond just the telemedicine and WhatsApp have you been doing? Have you been working to create any sort of communication strategies with not just participants, but also communities?
As of now, I'm not sure I should say yes or no. We are trying our best to make sure that we engage the media guys, but because now meetings are restricted, we are using web media like the radio stations to communicate to the communities. To the participants, we pray and hope that they also listen in. We've been encouraged by the phone-in calls that we get because we have all the doctors' contacts given to the participants, and my phone and my team telephone contacts are also given to the participants. We are getting some feedback from the communities, but we think the lockdown makes it hard for us to do what we thought we should be doing.
Great.
Good afternoon.
Oh, go ahead, Lynette.
Good afternoon, everyone.
Hello.
Hi, Lynette.
Hi, I want to give updates from Kenya. I'm Lynette Okot. I work for LVCT Health, and we do HIV prevention. For us, LVCT Health as an organization is part of the National Community Engagement Task Force on COVID. And for us, we managed to reduce number of staffs from the clinic. So most of the staffs are working from home. So we have very few staffs in the clinic. And we have a bulk SMS that sends messages to our clients so that they are able to be kept abreast of everything. And you also have a call center, 1190, where they can call in and find out or get information or telecounseling. Beyond that, we managed to get them drugs for longer periods so that we are sure that they have drugs, and to allow us to have social distance whenever they come to the clinic. Unfortunately, we are not able to send them drugs where they are, so they come for them, but we're able to have them fewer come to the clinic so that we have enough social distance and also have enough of hand washing facilities in the clinics.
Lynette, you mentioned that you are unable to send treatment to individuals. Now, I'm wondering if the situation came to a point where there was, say, in Kenya, there was.
Okay.
Sorry. Okay. Sia. Okay. So
your question.
Yes, I was still asking. I was just disturbed by the noise. I was saying, do you have processes or procedures in place in order to be able to support patient access to their treatment in the event that there's a total lockdown in the country where you can't now, because you said at the moment patients have to come to the clinic in order to access their treatment. So in the event that they can't now come to the clinic, do you have like procedures in place on how you are going to deal with that? And I would also like Sia to also weigh in on that question, because he works in South Africa. He works for Think, to also tell us about what they are also doing, because TB patients, they'll continue to need their treatment even if we have, say, an extended lockdown in South Africa. continue, Lynette.
Yes, so in the process of a total lockdown, the services that we offer are part of essential services. So the clients are can advise on the best way this can be sent to them. So this can be sent to them either through courier or Uber services. But for now, that's still not a challenge yet, because the only thing that we have now is a curfew. So patients can still, our clients can still get to the facilities between 5 a.m. to before 5 p.m. because the curfew starts at 7 p.m. But yes, if there's a total lockdown, drugs will still get to them through models that they'll advise.
Hello.
Hi.
I think I want to input. Thank you so much, Jessica and Melissa, for the invite. It's a bit different because we are guided by the national adherence guidelines, which have been amended in South Africa to accommodate for make sure that there's no treatment interruption, especially for our TB clinical trials, because we're still providing a clinical trial treatment and versus also standard treatment of care. So the recommendation was that we should give patients 2 months supply of their treatment, and then and we had to enter into a negotiation with our sponsors for the clinical trial to say this is what we're going to be doing, and we're guided in terms of data capturing. How are we going to be able to capture the visits, because the visits are now different versus to the 2 months supply. What is good is that most of our patients are already stable patients, so they are not infectious patients. So they're getting 2 months supply and they're getting daily telephonic support. On one hand, with the TB practical MSF clinical trial, we have implemented way before COVID-19 lockdown period, something that you call video dot. So patients, they call us, they all receive, all 89 patients receive cell phones, which has data. So every morning, our data capturers and our data officers receive video dot messages and upload these videos where patients are taking treatment through video dots. They tell us how are they feeling. And the good thing about video dot is that we also get to see, because we see the patient face every day, and we get to know how is the patient feeling. They tell us how are they feeling, and there's a clinician online which is able to answer if there's any serious adverse events that may be able to occur. So those are the modalities that we are currently looking at. Because TB treatment is regarded as an essential service, should the lockdown continue in South Africa beyond the 16th of April, we are hoping they still have treatment, but we might need to door-to-door deliver the treatment to them, because transportation is an issue at the moment. Taxis are only operating at a certain level, and we may not really go and pick up the patient to bring them on site. So we are also looking at amending what could happen if the COVID-19 lockdown period has been extended beyond the 2 month treatment, and the video dot strategy, which is currently in place for those who are still taking treatment.
Thank you so much. Thank you so much, Sia. I'm conscious of time, and yet we also want to ask some of these great questions that are coming up in the Zoom group chat. So can you please share with us, anyone can jump in here. So I know that most research sites have already developed strong network of mentors and peer educators and community working groups that they've been working with to promote accurate information about HIV, etc. In what ways have you been, as different sites, have you been using these networks that you've created in the community to talk about COVID or in the COVID response?
Hello. Hi, Tim. Oh. Hello.
Hi, Jane. Go ahead.
This is Jauhara
Hello.
Nanyalo from Uganda. Hi, this is Jao from Uganda.
Hi,
Thanks,
Jack.
Hi, everyone on the call. I'm happy to have the opportunity to speak to the team about how our community and generally the site is coping up with COVID and how we are utilizing community networks in trying to educate the communities about COVID. I must say that in our country, we are guided by the messaging from the Ministry of Health. So we are not reinventing any wheel, but we are using approved messages that the Ministry of Health is using. And in that context, we've been able to speak to the different, to put my response to context. I am coming from a research institution that does both biomedical research work and provides comprehensive HIV care and treatment. So we have a huge network of healthcare workers that we work with for care and treatment programs. And through, at the advent of COVID, we utilized the CME sessions at the different facilities, and then we were able to provide approved messages to the health workers, and that is Ministry of Health and WHO messaging. And we had opportunity for face-to-face interaction to have questions from the health workers responded to by medical or by medical teams. Specifically to our community, local people or peers that have been supporting us with the HIV trials, I must say that not much has been done in terms of facial interactions, but we have the opportunity to share some information on WhatsApp groups. We coined out a name that we called the special advisory groups. So we have networks of those on our WhatsApps, and we've been able to share messages to those groups. Just to tackle the issue about the challenge and how we've been able to work with the communities in this era of telecom promotion, I want to add my voice to Vincent that our country's utilization of internet-based platforms is just growing. It's still at a low scale, and therefore not so many people that we've been working with in studies or programs are utilizing such platforms. So the most popular way of reaching out to people is through the provided telephone contacts that are on their files, through their peers or teams that we worked with when we're reaching out to them. For treatment, for HIV positive clients whose treatment may have been affected by the COVID-19, we are reaching out to them physically. But of course, putting in the perspective of the prevention measures that are already stipulated, a bit of distance, but yes, I must say it's hard, but we are taking the drugs to the people. And that's happening, and we are working closely with the clinicians and the outreach teams and yes, we are taking drugs to them. Over to you, Melissa.
Hello.
Hi, Philister. Please go ahead.
Okay, for Philista Adiambo from Kisumu CRS. And so far, in terms of messaging, we've been able to develop some fact sheets on COVID-19. And we've also have material from the Ministry of Health. We've been able to pin the posters around the clinic and also out of the health facilities. And when it comes to engaging our participants, we've maintained touch with our community advisory board. So through WhatsApp, we have discussion there and they are able to tell us anything that is happening in the community and we address immediately. We are also able to engage them through virtual means, through Zoom. So we had a meeting with them through Zoom and had a very good discussion on the COVID-19 and different protocols that are coming up for COVID-19, like the chloroquine one that is soon going to begin in our malaria branch. Over.
Oh, Phyllis,
So
I
I just want to.
I think we lost you, but I do, you know, in the last few moments of the call, hopefully we can get Phyllis back to just finish that thought. But there are some really great questions and conversations popping up. So I do want to just get to sort of the next question. So Phyllis answered this idea of how you're utilizing cabs in this time, which is one great question. I'm also wondering about how others are utilizing the cab networks that they have, and in particular, Vincent and Zhao, since Uganda seems to have the sort of biggest restrictions about meeting in persons right now, how are you two handling outreach to cabs and the networks that you have already have established?
Okay, just to respond to that, I've talked about using the cab, yeah. So we are having meetings through Zoom, and we are able to discuss what is going on. So what we do is send them some time bundle money for tokens for internet, and then we are able to connect them. Before we were able to have a Zoom meeting, we had to train them on how to connect, and we successfully managed to do it.
Great, very helpful. Vincent, Zhao, do you have any answers to that final question?
Thanks, Jessica. The CAB at the site have been very helpful. Most of the information that we get and the views that we receive from the communities are informing our responses on how to address issues to do with the continuity of trials and also give facts about the COVID disease. But as Zhao earlier on mentioned, we still have limitations because the challenge now is that we cannot use Zoom like our colleagues in Kenya because of the technological limitations that we have here in Uganda. But overall, the community advisory boards and our network has been very helpful in informing us as to what we need to address in terms of giving accurate information to the communities under our situation.
Great. And there was actually a question that came in, and this is for everybody, but Sinead, I'd just like to ask you first and just hear from maybe one or two others. Are participants, as they coming in, are they being tested for COVID-19? And how long do those results take to get back?
Yeah, I can speak to my experience. It may vary from setting to setting, but the approach up until now has been to do symptom screening, and that can take the form of just verbal screening versus in some places there's temperature screening. And anyone who has any symptoms, they are then taken to an isolation area, and depending on what capacity exists at that site, they can be swabbed, sampled, and their samples sent off for testing. The critical thing then is how to get them home. So if they do in fact have COVID-19, and so there, I think there have been different approaches to doing that. But then, if participants do have symptoms and they are, they are at clinic, it's possible to test. The other thing that's happening is that there is a lot of effort being put into pre-screening. So before people come into clinic and before they're even picked up for their visits, that there are phone calls to participants to ask about the symptom screen, and if they report symptoms, to actually refer them then to testing sites, which are being identified throughout communities as the response is scaled up, and also kind of linking them into the community screening programs that are happening in particular areas. There were initial constraints around scaling up screening, but that has changed as the response has evolved. There were initial supply constraints around things like swabs. That is changing, but the fundamental, I think, is to rely very much on symptoms, because if people have symptoms, they're more likely to be shedding virus, and at the end of the day, the test is looking for virus. As we get other tests, so there's been a lot of discussion about antibody testing, but there are tests of variable quality that are in the market. So part of the initiative that are being taken by regulatory authorities in the region has been to identify a set of tests and to try to kind of validate those tests so that they can be used. And then those will give us different information, not necessarily who's currently infected, but who has been infected and has antibodies and could potentially therefore be immune, and so can return to work. So those are the two strategies, and both of them have value, but it's also kind of why there has been a strong focus on identifying people who are symptomatic initially with these PCR testing.
Great, thank you, Sinead. And I'm just going to hand it over to Phyllis. Can you answer that question quickly? Because I know you're doing something a little differently in Kenya. How are you testing folks for COVID-19? Perhaps we don't have Phyllis. So in the last just a couple of minutes, I do want to thank everybody for participating, and I recognize that we have not gotten to all of the wonderful questions in the chat function today. So we will be developing an FAQ to send around for everybody who attended and could not attend this webinar today.
Yeah, thank you so much. Thank you so much, everyone, for being a part of this conversation. We do recognize, as Jess said, that we didn't completely answer all the questions that have been posed, and we didn't really exhaust this conversation. So we will be organizing another webinar that will touch on this impact of COVID-19 on the work that we do, and we will advertise it again on our networks and via email. We've also developed a short survey question, which we will share the link here now on the group chat for you to access and maybe answer a few questions about this webinar so that we can improve the webinar series. But also we will share the link via email. Thank you so much.
Great, and thank you so much to all our presenters today. In particular, Sinead, thank you so much for your time and expertise on today's webinar. And again, we look forward to hearing everybody in the weeks to come. Have a wonderful afternoon, all.
Thanks, everyone.
Thanks, everyone. Great to hear from you.
Thank you.
Thank you.
Bye.
Thanks, everyone. Bye.